welcome to this postgraduate lecture series as part of the MedEClasses initiative in which we try to cover the entirety of pediatric endocrinology over the 36 modules covering different aspects. And we have been covering electrolytes for the last few months. We already covered hypo and hypernatremia as well as hypokalemia. So today we're going to finish off the electrolyte module using the module on hyperkalemia. Now, hyperkalemia is a scenario which is usually an acute emergency and we don't encounter in terms of chronic causes, but that can have huge implications in terms of evaluation and management. So we had this 1-month-old child who presented with reduced feeding, and this child had not gained weight at all in that perspective, and investigations showed hyponatremia and hyperkalemia. So usually we talk about sodium and potassium being linked. And when we discuss electrolyte, we said that whenever your sodium goes down, generally the potassium goes up. When your sodium goes up, the potassium goes down. So this is again going a situation where the sodium is low, potassium is high, suggesting that there is a problem in the renin, angiotensin, aldosterone system. Now, further workup, of course, the first thing you will consider in a child would be to exclude congenital adrenal hyperplasia or adrenal hypoplasia congenita. 17-hydroxyprogesterone and cortisol levels were both normal. Now, if we go further our algorithm, we found that PRA and aldosterone levels were high. So we had a child who had a high aldosterone and despite that had hyponatremia and hyperkalemia, indicating that we are dealing with an aldosterone resistant state. So this led to the diagnosis of quote-unquote pseudo-hypoaldosteronism. But here comes a catch. So whenever you're making a diagnosis which is rare, you have to think of other possibilities. And we'll discuss subsequently that a pseudo-hypoaldosteronism-like state can be induced via infection and obstruction. So this actually happened to be a UTI in the setting of obstructive uropathy, which resulted in a transient aldosterone resistance, and that caused this scenario. So whenever you're diagnosing these scenarios, think about obstruction and infection, which becomes important in that regards. Now, this is the format which we'll follow. We'll start off a bit about pathophysiology of hyperkalemia. Then we'll move forward towards criteria and etiology with Dr. Vibha. We'll be discussing about, then I'll touch base about assessment and management. And finally, we'll have a quick, interesting scenarios and question answer sessions which Dr. Manoj will take forward. So all of you can participate in that using the chat option subsequently. We'll also be taking the questions at the end of it in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources with regards to pediatric endocrinology, besides a number of courses and our e-learning portal in the YouTube channel, and the various courses which are available, including fellowship programs, diploma programs, and we have an exclusive course for postgraduates which covers all these modules over a 3-year period, specifically for pediatric postgraduates in that perspective. You can also follow our grand rounds, which are more in a pediatric endocrine perspective, symposiums which happen regularly, in this PG lecture series, which we plan over the next 3 years to complete the entirety of pediatric endocrinology. You can also have a look at our multiple publications, which are there also in the form of physical as well as virtual platforms and a mobile application. 3 major organs which are regulating the potassium homeostasis. It's largely the intestine and the kidney. But remember, the most potassium in the body is inside the cell. So you can consider cellular compartment as also an important organ, or let's say a repository of potassium in that perspective. Now, if you have a problem in the intracellular compartment wherein your shift is there, so if you've got huge amount of money which is there in the bank, and suddenly the bank gives you all the money, your liquidity goes up, a same scenario will happen that your potassium will go up immediately in the circulation. Now, this is usually an acute phenomena. But remember, whenever you have a lot of load of potassium, if your kidneys are functioning properly, they will excrete the potassium in that perspective. So this will be an acute, life-threatening condition like what Vibha talked about in the form of a hemolysis, which may happen in that scenario in a blood transfusion reaction that will cause hyperkalemia, but this will be transient in that perspective. Very importantly, to have a chronic hyperkalemia, you need to have a problem in the renal system. So either the glomeruli or the tubules, or you have a problem in the renin, angiotensin, aldosterone system, which is regulating all this process. All these will cause chronic hyperkalemia. So any condition in which you have a chronic hyperkalemia, you have a problem either in the kidneys or in the renin-aldosterone system. And this is something which will result in reduced potassium excretion, and you will have a chronic hyperkalemia. The concept again becomes important that anybody who is hyperkalemic should have an increased urinary potassium. If you have hyperkalemia with decreased urinary excretion, you are basically talking about a scenario in which there is a problem in the RAS axis. And this forms the basis of the use of urinary potassium to creatinine ratio and transtubular potassium gradient, the two things which I'll talk about when we talk about evaluation of hyperkalemia in the assessment of hyperkalemia. So individuals who have got a high serum potassium but less potassium in the urine, you're thinking of a renal cause in that perspective. Now, if we talk about intestinal, oral, or intravenous load, as we've talked about, if you get too much potassium, the kidneys are very efficient. They will basically wash it out. So this will basically be a self-limiting scenario, which is something which we won't be worried about in that perspective. So major chronic causes will be renal or adrenal. This is what we'll talk about in that perspective. Now, as large amount of potassium is in the cells, we need to understand about the cellular flux of potassium. We know that the potassium concentration in the cells is around 40 times more than the plasma, and around 99% of all potassium is inside the cell. And this is basically maintained, this gradient is maintained against a sodium gradient as well, which is pretty much similar, like 14 times, using a very, very important sodium potassium ATPase, which is an active transport system, which eats up a lot of ATP of the body, which allows this exchange of potassium inside and sodium on the outside. And this channel becomes very, very important. An important regulator of this channel, of course, is insulin. And if you have insulin deficiency states like diabetic ketoacidosis, your potassium will basically be coming out in that perspective, and you will have less total body potassium, but the potassium in the plasma may be more because of this insulin deficiency. And this we have discussed a lot in the setting of diabetic ketoacidosis. As soon as you give insulin, the potassium shifts inside the cell and you will have a severe hypokalemia in that perspective, and something this is important to understand. Now, remember, the proton and potassium have an antagonistic action. If you have systemic acidosis, the body will like to push this potassium inside the cell so that the blood doesn't have, the plasma doesn't have a severe acidosis. And in exchange of this proton, you will have an excess of potassium. So if you have metabolic acidosis, there will be a rise in serum potassium level. And this we'll be discussing in terms of assessment, that for every 0.1 decrease in pH, you have a rise of potassium of around 0.6. This again is very, very relevant in the setting of diabetic ketoacidosis. Once you correct insulin deficiency, once you correct acidosis, suddenly all the potassium will go into the cells and you will have severe hypokalemia. So for every 0.1 decline in potassium, 0.1 decline in pH, your potassium goes up by 0.6. This is very important. So if you have a pH of, let's say, 7, you have to subtract 2.4 from the actual measured amount of potassium from the extracellular fluid to get the exact amount of true potassium status. And this is what is important in that perspective. So if you have acidosis, you will also have hyperkalemia. Now, beta agonists also activate the sodium potassium ATPase channel, and they will help out in terms of treatment of hyperkalemia. They will push your potassium inside the cells, and that's what makes them effective in that perspective, in that regards. Now, as I've discussed, the major cause of chronic hyperkalemia is the lack of renal excretion. So we need to understand a bit about potassium handling by the kidneys. Now, most of the potassium which is coming to the blood is filtered, and around 100% of it is actually absorbed in the proximal tubule. So whatever potassium actually excreted is not the one which is filtered. So remember, all that you have filtered is absorbed here, and then the active egress of potassium, the active excretion of potassium actually happens at the level of collecting duct. And the driving force of this is the epithelial sodium chloride channel. Now, this epithelial sodium chloride channel causes the sodium to enter into the plasma, and along with that, you also have entry of chloride. Now, the chloride moves slowly as compared to sodium. So there is a electronegative environment within the lumen of the collecting duct. And if you have electronegative environment, it will basically drag all your positive ions. And that's how your potassium comes into this lumen, it is lost. So the entire excretion of potassium, which is actually happening from the kidneys, is happening because of this exchange of effectively the sodium with the potassium in the epithelial sodium chloride channel. Other positive ions like proton, like magnesium, like calcium may also be lost in exchange to this sodium entry, but it's largely the potassium and proton which are important. And we discuss a lot when we talk about RTA is that the ammonium production is the one which determines the excretion of proton. So now from this, what we understand is that if you have reduced delivery of sodium in the collecting duct, you will not have enough sodium entering out from there. So the potassium pump or excretion will become less. So if somebody is dehydrated, somebody is not having any sodium in diet, you don't have enough sodium to exchange for potassium, you will develop hyperkalemia in that perspective, in that regards. And that's something important to understand. Now, the major regulator of the epithelial sodium chloride channel is aldosterone, acting through its mineralocorticoid receptor. In a nutshell, the only effect of aldosterone is to push the mineralocorticoid receptor action, will push the epithelial sodium chloride channel from the cytoplasm to the membrane. So in a way, it is now making the membrane more permeable to sodium. Just like the major effect of vitamin D is to increase the capability of absorbing calcium, the major effect of aldosterone is increasing the availability of the epithelial sodium chloride channel, increasing the levels of expression, causing sodium intake. And of course, if you're taking in sodium, you will have to push potassium out. So defects in the ENF defect channel, mineralocorticoid receptor or aldosterone will all cause hyperkalemia. Now, aldosterone is largely regulated by the renin-angiotensin-aldosterone system, which in turn is regulated via potassium and volume. So if there is hyperkalemia, as discussed earlier, if you have increased load, if somebody is having a lot of potassium, the kidneys will start producing renin. If there is hypovolemia, again, your renin axis will get activated, and this renin will convert angiotensinogen to angiotensin 1, which will then be converted via the angiotensin convertase enzyme in the lungs to Ang2, which will cause production of aldosterone. So this entire renin, angiotensin, aldosterone system will regulate the epithelial sodium chloride channel in that perspective. A very important thing to remember is that the major regulator of aldosterone secretion is renin and not ACTH. And that is why when we differentiate primary adrenal insufficiency from central adrenal insufficiency, there is a big difference in terms of potassium. Now, both of these conditions will have hyponatremia, but hyperkalemia will only happen in a primary adrenal problem because there the aldosterone production is defective. You will basically have no hyperkalemia if you have a central cause because their ACTH is affected, but renin and this whole system, renin-angiotensin system is working. So central adrenal insufficiency because of a hypothalamic or a pituitary cause or ACTH deficiency or a ACTH resistant state like familial glucocorticoid deficiency will not have hyperkalemia. They will predominantly have hyponatremia. On the other hand, if you have isolated aldosterone problem, aldosterone deficiency or aldosterone resistance, you will have more of hyperkalemia. Your hyponatremia will be less. Now, what is the reason for that? The reason for that is that cortisol inhibits AVP production. Cortisol is also required for excretion of free water. So in conditions where you have a combined cortisol and an aldosterone defect, like adrenocortical insufficiency, you will have increased AVP, which will cause free water retention, causing hyponatremia. So hyponatremia will be maximum if you have both glucocorticoid and mineralocorticoid deficiency. Potassium will also be high. If you have isolated glucocorticoid deficiency, you will just have hyponatremia. Potassium will be normal. If you have a mineralocorticoid problem, mineralocorticoid deficiency or resistance, the major problem will be hyperkalemia, mildish hyponatremia. So because they will present late, your potassium may go up to 8, 9, or 10. So that's an important concept to remember. Now, of course, if there is a problem in the kidneys, if there is a problem in renin, angiotensin convertase enzyme, and a lot of these drugs, the ACE inhibitors, the ARB, they will all act on this direct effect. Primary adrenocortical defect, aldosterone synthesis problem, a mineralocorticoid receptor problem, or an epithelial sodium chloride channel, all will cause decreased potassium excretion and will result in hyperkalemia. Now, if you are losing more potassium, remember, proton and potassium are competing with each other. So if you have hyperkalemia, body will not be, if you're losing, your potassium loss is less, the proton will obviously compete in that perspective. So that will also impair your production of the acid excretion as well. And that way it will cause a metabolic acidosis, which is mild. So anybody who has hyperkalemia will have mild metabolic acidosis. And opposite, if you have metabolic acidosis, you will have hyperkalemia. So potassium and proton basically go up together. And this is the mechanism of what we call quote unquote type 4 RTA, in which you have hyperkalemia, which causes a bit of metabolic acidosis in that perspective. So remember, proton and potassium are linked in that regard. So to summarize the pathophysiology, the problem could be extracellular shift, which is an acute problem like metabolic acidosis, tissue lysis, insulin deficiency. If you're able to manage acutely and if your kidneys are fine, there will be no problems. Increased intake will not cause hyperkalemia. If you give too much IV potassium, that may, in somebody who has immature kidneys like preterms, or if there is a renal insufficiency, potassium salts, but this will be very, very unlikely. Predominantly what we're talking about is reduced renal loss because of a primary glomerular problem, effective hypovolemia where sodium delivery is less, and therefore you can't exchange the sodium to potassium, a renin, angiotensin, aldosterone system defect, which we discuss in detail, lots of drugs, ACE inhibitors, angiotensin receptor blockers, spironolactone, they will cause that. So just to summarize, hyperkalemia can be because of increased intake, oral and intravenous. Remember, this will be self-limiting if your kidneys are working fine. Only if you have renal dysfunction, the problem will become more. It may be because of a cellular shift, because of acidosis, channelopathies, or cell lysis. Again, you will have a sudden rise. And if your kidneys are fine, it will be not sustained. It can be because of a reduced renal loss, which may be a renal problem like glomerular or a tubular disorder associated with hemodilution, fluid overload, reduction in uric acid, and decrease in hemoglobin, or RAS defect, which is characterized basically by dehydration and hemoconcentration.